So this morning, I will talk about the article of the effect of flexible versus stable supportive shoes on knee osteoarthritis symptoms, which is a randomized control. It was published in the Annals of Internal Medicine 2 months ago. I have no conflicts of interest to disclose. And the objective today is to review the evidence related to shoe recommendations for knee osteoarthritis, and to critically appraise the study's methods and results, and to discuss the study's implication for clinical practice. Knee osteoarthritis is a global health problem that causes significant pain and disability, affecting around 263 million persons around the world, leading to reduced quality of life. The treatment of knee osteoarthritis remains largely palliative. Self-management is universally advocated as a treatment for osteoarthritis. It comprises of symptom management, exercise, and weight control. Appropriate footwear is a form of self-management. Yet, in terms of its recommendation, there's very little evidence to inform appropriate footwear choice for people with osteoarthritis. A systematic review in 2018 showed that there was insufficient evidence for recommendations when it comes to footwear for knee osteoarthritis pain relief in older adults. Here on the first picture, we have a little bit how the knee osteoarthritis are represented in 4 grades. So we have doubtful to severe, and the radiographic classifications of these 4 grades from minute osteophytes to joint space reduction and subchondral sclerosis. Medial tibiofemoral osteoarthritis is more common than lateral osteoarthritis. This suggests that abnormal medial knee loading is implicated in knee osteoarthritis pathogenesis, and some shoe increase more this medial knee loads than others. So from a biochemical point of view, by providing cushion to the lateral side of the foot, we create a valgus alignment of the knee. So we're closer to this vector, and this brings the knee closer to the vector and decreases that knee medial load. Stable supportive shoes have been popular as they provide this medial arch, but they also have been shown to increase paradoxically this medial knee load. So the authors of the study that I will present today have previously compared flat and flexible shoes to stable and supportive shoes, and have found that flat and flexible shoes increase less that medial load on this cross-sectional study. However, we wonder if this translates to improvements in knee osteoarthritis symptoms, and does it slow the structural disease progression? So the study is the effect of flat and flexible versus stable supportive shoes on knee osteoarthritis symptoms. And the study design, the subjects were recruited in the community of adults in Australia. They were aged 50 years and above with moderate to severe symptomatic radiographic medial knee osteoarthritis. The intervention were the flat and flexible shoes worn for at least 6 hours for 6 months. The comparator was the stable and supportive shoe. And the primary outcomes were the self-reported measures of pain while walking and physical function at 6 months. In terms of the secondary outcome, the additional pain and function measures, physical activity and quality of life, as well as adverse events were recorded. The overall average pain during walking over the previous week was assessed by using an 11-point numerical rating scale with terminal descriptors from 0, no pain, to 10, worst pain possible. And patient had to achieve a minimal clinically important difference of 1.8 units to really show any change. And in terms of the difficulty for physical function, that was assessed by using Western Ontario and McMaster University's osteoarthritis index with total score ranging from 0 to 68, and with the minimal clinically important difference of 6 units. All the scales of this study were self-reported scales. Otherwise, this was a 2-group pragmatic comparative effective superiority RCT. and they recruited participants in the community. The inclusion criteria were patients of 50 years or older who had knee pain on most days of the past month, and who reported knee pain on an average of 4 or greater on the 11-point numerical rating scale during walking the past week. Obviously, because we're looking more at this moderate to severe degree of knee osteoarthritis, we use the Kellengren-Lawrence grading scale, and it had to be 3 or more to be recruited. In terms of the exclusion criteria, authors excluded patients who had more lateral joint space narrowing than the medial because they were looking at this medial knee load effect. And they also excluded patients who had a recent knee surgery or any planned surgery, or who were using shoe orthosis and customized shoes. So in terms of the two groups of shoes, these were the flat and flexible shoes, and these were the stable supportive shoes. They were more like running shoes. And how they differentiated was really in terms of these 5 criteria. So in terms of their heel height, shoe pitch, which is the difference between the forefront of the shoe and the back of the shoe, and this kind of difference in height. Otherwise, the arch support, the sole flexibility, and the weight of the shoe. So each participant had the chance to choose 2 different pairs of shoes to maximize the external validity and to promote adherence, because authors propose that persons do not typically wear 1 pair of shoe all the time. The shoes were fitted by a researcher and provided to participants at no cost. And the final questionnaire was completed on paper or electronically at home 6 months after the randomization. To minimize any missing data, the participants were all given a gift voucher of Australian $50 to complete both questionnaires. And the participants were instructed to increase their shoe wear by 1 hour per day until they were wearing the shoes as much as possible, for more than 6 hours per day for 6 months. So otherwise, there was limited disclosure to patients in terms of what the study was, and that was a way for the researchers to blind the study. They were just given the information that they had to wear shoes, and they wanted to check on the effects of the shoes, but they were not told the class of shoes and the specific effects that they were looking for. The adherence was self-reported in monthly in logbooks, and the shoe wear hours per day for 7 consecutive days was also asked to be reported. And at 6 months, these overall ratings were taken and compared. So in terms of the results, there were 164 participants recruited from August 2017 to November 2019 in Australia. And the major reasons for exclusion were mild to no radiographic osteoarthritis or non-medial osteoarthritis. The lack of interest in participating or the inability to attend appointments were also another reason, but less than the previous reason. And at 6 months, 98% had completed primary outcomes. So only 3 patients were lost on follow-up. In terms of the table 1, baseline characteristics of the patients, mostly these 2 groups were similar. I highlighted some minor differences, but we can see that the stable supportive shoe group had more participants in the pronated foot posture, which is theorized with less medial knee load in the biomechanical literature of for knee osteoarthritis. But both groups had similar rates of abnormal and normal foot posture participants. Otherwise, the flat and flexible shoe group also had more subjects treated with topical NSAIDs. More of the stable and supportive shoe group or participants in the stable supportive group expected a larger improvement. And this could affect a little bit the results that I'm going to talk about later. But that comes also from the intuition that a cushioned shoe is better. So coming to the change within groups and difference in change between groups in their primary outcomes, so overall average knee pain and physical function, there was a difference of 2.1 in mean change for overall average knee pain in the stable supportive shoe group versus the 1.1 in the flat and flexible group. The p-value was 0.01, which was significant, but there was no significant difference between the two groups in terms of physical function, with 6.7 of mean change for the stable supportive group and 4.7 of change in the flat and flexible group. The p-value for that outcome was 0.167. There was no significant differences in all the secondary outcomes, which are listed here. So otherwise, this table is from the supplement material, but in terms of the percentage of patients who reported global improvement, and again here the pain and function were rated by either much worse or much better. So if the participants rated moderately better or much better, it was classified as improved. So in the stable supportive group, we had 58% of the participants wearing these shoes that achieved a clinically relevant reduction in walking pain. And this is compared to the 40% of reduction in the flat and flexible group. So going forward with the critical appraisal of this study, to answer the question of are the results of the trial valid? So the participants were randomized by permuted blocks, stratified by the KL grading, which was the osteoarthritis radiographic grading. The schedule was prepared by a biostatistician and maintained by researchers not involved in the recruitment or administration of primary and secondary outcomes. Both group of subjects were mostly similar, except that less of the stable supportive group were on the topical NSAIDs, and more of this stable supportive group participants were expecting a larger improvement, which may favor a better self-reporting in terms of reduction of pain. In psychology, there's this kind of confirmation bias where if you expect something more, and this thing can happen more. So otherwise, both groups were treated equally, choosing 2 pairs of shoes, and were compensated the same amount of money at the end of the trial. So continuing with the results of the trial valid, all randomized patients were included in the analysis and remained in their groups. Only 3 patients were lost on follow-up. So that's a pretty high rate. The measures for the primary outcomes were subjective, self-reported by patient in terms of pain and functional status. There is the inherent risk of bias with retrospection and self-report information. And there's also room for bias with regards to the hours of wear, as if the patients were asked to wear more than 6 hours, and you want to keep on the study, you want to get your compensation, you tend to include, you tend to actually, overestimate the number of hours of wear. And so in this study, the number of hours of wear that was reported by patients were around 8 to 9 hours. The patients were blinded by a process of limited disclosure. So again, they were not informed of the shoe models, not informed of the study hypothesis by which group they were allocated until the study was completed. The authors wrote that the research staff administrating and entering the participant reported data was blinded, but ultimately, I think that staff can easily determine what kind of shoe the participant was wearing, and clear division of tasks was not really mentioned in the study. So what were the results? The main treatment effect was the reduction in pain while walking that was larger in the stable supportive group than the flat and flexible group, but both had reduction of that pain in walking. More of the flat and flexible shoe group participants had adverse events, and these adverse events were mostly lower extremity pains, such as foot, calf, and knee pain. So the results of this study helped me caring for my patients. I think the population describing this study included, the population describing this study had moderate to severe documented knee osteoarthritis. So they all had x-rays to prove that. This is very nice. This is the population that I could see in our clinic who have complaints of knee pain. But I think the population were younger, with the mean age of 64. And there was this inferred fitness that comes with the fact that they wear almost 9 hours of shoes per day. This treatment is, I think, less feasible in our setting. We're mostly advocating for our patients to choose a safe shoes to wear to prevent falls. And I think that, taking this extra time to counsel around shoes for knee pain could be something that's doable if the patient inquires about it. But in reality, I think it's really hard. It's really hard to convince someone to change their shoe habits. I don't know for you, but I have quite a few patients who love their Crocs, and even shoes who, that don't really fit. And that becomes actually more a fall hazard. And so at the end of the day, I think this was a very more fit population with no fall risk described, no mobility issues described, and no mobility reported. And it would be an interesting conversation to have with with patients in terms of their shoes. If the patient voluntarily reported or asked about it, I might recommend the stable supportive shoes just for that pain relief. But the study itself doesn't convince me to change my practice to go beyond the CGA to recommend stable supportive shoes. So the bottom line, the study was blinded by limited disclosure, or CT, with subjective outcome measures self-reported by participants. And the stable supportive shoes provided greater reduction in pain while walking, although both groups reported less pain. There was no change in function in both groups and no comparison to patients' usual shoes. And the participants of this study were fitter, younger than our population of interest. And lastly, it would have been interesting to kind of further understand by which mechanisms the stable and supportive shoes improve pain. And also, I wonder, if we had X-rays done after this study, what would the X-ray show? And, to answer the kind of question of, is there any structural change or disease change after wearing these shoes for a longer period? So thank you very much for listening. These are my references.
Thank you very much, Jenny, for an excellent critical appraisal, and your comment on how difficult it is to change behavior resonates with me. I see a lot of older individuals who suffer falls and insist on wearing their heels or their wedge, and the fashion statement is hard to change. There's a comment in the chat box from Marjorie Hammond: fall risk and lower extremity pain are interrelated. In addition to sensory deficits in the feet are interrelated. In addition to sensory deficits in the feet were in leather soles, may provide greater awareness of foot to ground. I also thought about just overall comfort of the shoe and how that influences your subjective assessment of those scales. And the other comment I might have is, I wonder if they measured the BMI or weight at the end of the 6 months or simply on entry, because their BMI, I noticed, was relatively high at 32 and 33. And I wonder what change that had over 6 months. Gary also has a comment. Please unmute, Gary.
Good morning, Jenny. Thanks very much for the excellent presentation. I just want to emphasize, I guess, one of the things you pointed out. So the primary outcome was a subjective outcome. The participants at the beginning clearly identified a preference, and then they're rating themselves, which seems to be extremely problematic in the absence of being able to do an objective outcome. And the sample sizes were relatively small, which means that randomization is less likely to work at creating equal groups. And you sort of emphasized two elements that were different, but when you presented your table of characteristics, there were several that were emphasized in yellow that showed differences between the groups. And I didn't have enough time to give myself a sense, did they consistently favor one group or the other? But then when you have small sample size, you often look for adjusting results for differences, because differences often occur between groups. And I didn't hear anything about them. First you have the subjective outcome with a group that thought they'd benefit, and then you had various differences that it didn't appear were adjusted for. So I'm wondering about the confidence that you have in this result.
So yeah, the reason why I pointed out that subjectiveness and the favoring, expecting better improvement from the stable supportive group, that was definitely an issue, and that's the reason why I pointed out. Thank you so much for your comment. The reason why I highlighted so many things, it's definitely came to my attention, but after really looking into it, for example, the pronated posture that was more in the stable supportive group, this is theorized with with less medial knee load, but even in the literature that I was searching for, it wasn't really clear if, supinated is less important. And so, it seems to conclude that both are problematic. But otherwise, going through and with the highlights, I couldn't find that much, things that would favor one more than the other. So that's why I didn't take the extra time to comment on them. But that's really a good comment. Thanks.
Thank you very much, Gary and Jenny. To ensure that we have sufficient time for the next presentation, we're going to move on, but I'm sure Jenny would be happy to take further questions or comments in the private chat function. Thank you very much for an excellent presentation. And next we have Dr. Alex Day, PGY4, who will take us through a recent study investigating delirium prevention in a high-risk group. So I'll ask Alex to start sharing his slides, please.
Sure, thanks, Dr. Gandel. Give me 1 second. All right. Thanks for having me today. So for those of you who don't know me, my name is Alex, and I'm PGY4 in geriatric medicine. And today I'm going to be talking about, as Dr. Gandel said, looking at intra-op dexmedetomidine for the prevention of post-op delirium in elderly patients with MCI. And we're going to be talking about not only the results of the study, but also looking at some of the delirium pathophysiology models. So I don't have any disclosures. This is a study we're going to be talking about. It's published in the Journal of Geriatric Psychiatry by Zi Xin, and this is a study out of Tianjin, China. In case you've never heard of Tianjin, neither had I. It's a small city of 15 million people, just outside Beijing. It's on the water. Seems like a nice place. So the research questions today we're going to be looking at are, firstly, whether or not intraoperative dexmedetomidine compared to placebo will reduce the incidence of post-operative delirium in elderly patients with MCI. And specifically, the authors are trying to show in this study that dexmedetomidine is effective by reducing neuroinflammation. So we're going to be investigating or exploring that question as well. So why should we care about delirium? Delirium, as we're all very familiar with, is quite devastating, associated with elevated risks of mortality, morbidity, extended length of stay in hospital, and also can increase the risk of dementia. The prevalence of post-op delirium in elderly patients after non-cardiac surgery has been shown to be as common as from 13 to 50%. And then looking at the pathophysiology of delirium, it's very poorly understood, unfortunately, which is probably the reason why we don't have any good treatments for it. And as we're going to explore, it's very complex and involves interactions between diverse factors, and ultimately leads to the disruption of large-scale neuronal networks in the brain that manifest as the symptoms we see in delirium. So this very complicated schema here is from Maldonado in 2017. And him and his team looked at 5 mechanisms that lead to these interrelated pathways, eventually leading to the symptoms of delirium. And so we're going to look at all 5 briefly, and the one in particular we're going to be looking at is the neuroinflammation. So on the right, we see the 5 blocks. The first one is neuronal aging. This is the idea that our neurons, just like the rest of us, as we get old, become more frail, more vulnerable to stress, and more likely to be injured in times of stress. We'll talk about neuroinflammation in a moment. And then the oxidative stress hypothesis is that oxidative stress leads to damage to cerebral tissues. And then there's the neuroendocrine dysregulation theory, which states that in times of elevated and prolonged glucocorticoids, the glucocorticoid exposure makes our neurons and synapses, again, more vulnerable to stress and injury. And then lastly, there's the circadian dysregulation theory, which indicates melatonin as one of the potential causes of delirium. And although this schemata is quite complicated, ultimately, these 5 mechanisms, in one way or another, will either increase the levels of dopamine or will lead to cholinergic deficiency. These 2 neurotransmitters are implicated quite commonly in the ultimate pathway leading to the symptoms of delirium. And this rings true for anyone who's seen an elderly, vulnerable patient who's taken anticholinergic medications or taken a dopaminergic medication. So we're going to be talking about the pathophysiology of delirium. Again, more specifically, we're going to be talking about the neuroinflammation pathway, because that's the pathway that the study I was looking at today is specifically showing that dexmedetomidine is regulating. So just to discuss the neuroinflammatory hypothesis in more detail, the theory is that with a surgery, with an infection, with pain, or with exposure to anesthetics, these all will ultimately lead to an increase in peripheral inflammation. And inflammatory factors such as TNF-alpha, IL-1, many others will drum up an inflammatory reaction peripherally, end up impacting the blood-brain barrier, increasing its permeability, allowing for an increase in cytokines to enter the CNS. And this then acts on microglia, which if you remember from medical school, the microglial cells are like the macrophages of the CNS, and they act on the microglia, and they will activate these to release further cytokines. And these cytokines can then either directly act on neurons to cause disruption of neural networks, or they can also cause the microglial cells to directly damage the neurons and the synapses. And in this way, we ultimately get to large-scale disruptions of neural networks, and this manifests in the symptoms we see in delirium. So this begs the question then, why do we see delirium most often in people with more vulnerable brains, people who are older, and particularly people with dementia? And so this diagram tries to indicate why that might be. And one of the foremost theories is that the cytokines, so for example, TNF-alpha, will act on the microglias, but in people with dementia, their microglias are described as being primed. And what this means is that when that TNF acts on the primed microglia, they will overreact to this signal. And the pro-inflammatory signal that the microglia receives drives them to be overactive, which will lead them to damage more neurons and can damage the neurons worse, more significantly, leading in cases to irreversible damage. And this is hypothesized to be the reason why delirium can potentially lead to extensive long-term cognitive decline. So in the neuroinflammatory hypothesis, there are many different cytokines that are have been looked at in delirium, but we're going to talk about these 5 different cytokines and enzymes because these are the 5 that the study I'm talking about today will ultimately be looking at. So as we mentioned, there's TNF alpha, and this is a pro-inflammatory factor. There's also IL-10, and IL-10 is does the opposite job of TNF alpha. It's an anti-inflammatory cytokine. So it's working against TNF alpha. It's trying to inhibit pro-inflammatory factors. And then there's matrix metalloproteinase 9, or MMP9. Now, this is an enzyme that is important for the blood-brain barrier. It's helping to degrade support cells so it can be rebuilt. And in many different studies, it's been shown to be an indicator of blood-brain barrier damage. So things that like stroke or TBI, traumatic brain injury, can lead to increases in MMP9. Glial fibrillary acidic protein, or GFAP, very similar to MMP9, but GFAP is found in astrocytes. It's a protein that is important for astrocytes, and it also maintains the blood-brain barrier. Again, it will be elevated if there's damage to the brain. And then there's heme oxygenase 1. This one is more indicated as a factor in the oxidative stress model, but I just mentioned it here as just one of the other enzymes that the study is looking at. So just a quick primer on what is dexmedetomidine. So it's a medication I'm sure we've seen used in the ICU. It's a highly selective alpha-2 agonist, and its effects are potent sedation. It's an anxiolytic, and it does have a modest analgesic effect. And in many studies previously, it's been shown to suppress systemic inflammatory processes. So the question of whether or not dexmedetomidine can help reduce the incidence of postoperative delirium has been studied before. This is the results of a meta-analysis from 2019 that looked at 6 randomized controlled trials that compared dexmedetomidine to placebo in the prevention of post-op delirium in elderly patients, patients over 65. And as you can see, it did show that dexmedetomidine significantly reduced the incidence of post-op delirium in this population. Unfortunately, in none of these studies did they discuss the level of cognitive impairment in these patients. It wasn't part of those studies. So the study that I'm talking about does factor that in. Now, those studies looked at dex versus placebo, but then there was a handful of studies that also looked at whether or not dexmedetomidine was better than propofol when sedating adults in the ICU. This meta-analysis looked at a handful of studies and showed that there was a significant benefit in dexmedetomidine compared to propofol in both reducing the length of stay for patients in the ICU and for reducing the risk of delirium in these patients. So let's go back to the study in question today. So this study's hypothesis is looking at dexmedetomidine and whether or not it's going to be reducing, they are hypothesizing that it will reduce the incidence of postoperative delirium in elderly patients with MCI. And they believe it will be able to be effective by reducing neuroinflammation and improving the permeability of the blood-brain barrier. So the study design was pretty straightforward. It's randomized, double-blind, placebo-controlled study. They were only including patients over 65, and these patients were all undergoing laparoscopic cholecystectomies. They had 60 patients enrolled, and they had 30 patients randomly assigned to one of 2 groups, with either the dexmedetomidine group or the control group. So in the dexmedetomidine group, they received a loading dose and then a continuous infusion during surgery. And then the control group just received equal volumes of saline. And from what I was able to read about dexmedetomidine, this amount of dexmedetomidine during surgery seems pretty standard. And the anesthetists were able to use further anesthetics with monitoring of bispectral index and other hemodynamic factors to alter the anesthetics further during the surgery for both groups. And then they were also collecting data on the cytokines that we discussed previously. So they were taking blood samples before induction, before suturing, and then lastly, 30 minutes after surgery. And they collected TNF-alpha, IL-10, GFAP, MMP9, and heme oxygenase 1. And then, as we'll see, compared the levels at all 3 times. In terms of inclusion criteria, other than the patients having to be over 65, the main one was the patients had to have mild cognitive impairment. And one of the important points of contention in this study is that they did a very poor job of standardizing a definition of mild cognitive impairment. So they included patients as being or as having mild cognitive impairment if they self-reported themselves as having subjective memory loss, or a family member brought forward that they had some memory concerns. They also defined MCI as a MoCA score of 15 to 25. They also defined MCI as MMSE less than 27. And they also used the clinical dementia rating scale of 0.5 points as being MCI. And then finally, they use an activities of daily living score less than 26 to indicate MCI. And maybe something we can discuss later when we look at the critical review. But I'm not sure what scale the activities of daily living score was on. I tried to find out what scale it would be. It wasn't indicated in the paper. And the other ADL scores I could find was the Barthel score and the CAT score, neither of which go above 20. So I wasn't even sure which scoring system that was. All this to say is that the MCI level, or the MCI score was, scoring was not standardized for all patients. In terms of exclusion criteria, they excluded pre-op delirium, which makes sense. They also excluded any patients with dementia, any severe liver or renal insufficiency, use of sedatives or other medications that could impact the study results if they had traumatic brain injury or if they had a history of alcoholism. In terms of the primary outcomes for the study, they were looking at post-op delirium, which they determined by a 3D CAM that was performed twice per day in the first 7 days of surgery. And if a patient was discharged early, they would call the patient up and perform the 3D CAM over the phone with them. They trained people to do the 3D CAM, and for people who haven't heard of 3D CAM, it's just the normal CAM, but it's being operationalized with standardized questions to ensure that all patients are being adequately assessed to a certain standard. And it's been shown previously to have sensitivity of 95% and specificity of 94%. So here's table 1. As we can see, the age of both groups was very similar. Not very old patients on the younger side of our elderly population. In terms of surgical time, again, no significant difference between both groups. PACU stay time, though, did have a significant difference between both groups. Patients that received dexmedetomidine did have a significantly longer stay in the PACU following surgery. Bradycardia is one of the known potential side effects of dexmedetomidine, so it's important to note that neither group had a significant increase in bradycardia. And then at the bottom there, we can see that in terms of comorbidities, the patients in the studies had very few comorbidities, but both groups had about the same level of comorbidity. So in terms of the results of the study, it did show that post-op delirium was significantly reduced in the dexmedetomidine group. those in the control group that received saline had delirium in 10 out of 30 patients, and those receiving dexmedetomidine only had post-op delirium in 3 of the 30 patients. Now the confidence interval below you'll see is very wide, and we can talk about that a little bit more detail later, but ultimately they did show that dexmedetomidine was effective, as has been previously shown in the studies that we looked at before. Now this is a bit of a busy slide, but we're going to go through it sequentially. So this is looking at the cytokines that we were discussing at time points T1, T2, and T3. And just to remind the group, T1 was before induction, T2 was before suturing, and T3 was 30 minutes after the surgery. So looking at A on the left side, this is TNF alpha. And we can see that for both groups, levels of TNF alpha, which is the pro-inflammatory factor, are significantly elevated from the baseline. But you'll also see that in the dexmedetomidine group for time 2 and time 3, compared to the group that received saline, TNF alpha is significantly reduced. So indicating that dexmedetomidine was responsible for reducing the pro-inflammatory factor TNF alpha after beginning the surgery. And then in chart B, this is IL-10, and IL-10 is the anti-inflammatory factor. You'll see that in both D group and C group, IL-10 was significantly elevated from the baseline, but that in the dexmedetomidine group, there is a significantly elevated level of IL-10, which is again anti-inflammatory, which would indicate that dexmedetomidine was reducing the inflammation in these patients. And then in group C, this is GFAP that's found in the blood-brain barrier, important for that. And again, elevated from baseline, but again, in the D group, we have slightly or significantly less elevation in GFAP in the D group compared to the C group, again, indicating that dexmedetomidine was important in reducing the permeability, or sorry, I should say improving the permeability of the blood-brain barrier. And then we find, again, same results in MMP9, elevated from baseline, but in the dexmedetomidine group, it also is significantly reduced compared to the C group. And then finally, heme oxygenase 1, which was more an investigation of the oxidative stress hypothesis. There's no difference significantly from baseline, nor is there any difference between D group and C group. So overall, this should demonstrate that dexmedetomidine was successful in reducing overall inflammation, and potentially that could have also been due to it improving the permeability of the blood-brain barrier. So the conclusions that the authors come to is that dexmedetomidine perioperatively, it can reduce the risk of post-op delirium in elderly patients with MCI. And as we've discussed, that mechanism is likely due to reduction of neuroinflammation and lowering of the blood-brain barrier permeability. So let's go through some appraisal of the study. So was this assignment of patients to treatments randomized? Yes, randomized 1-to-1. They used an independent statistician. Were the groups similar at the start of the trial? Now, the baseline characteristics that we looked at, age, comorbidities, these were similar between both groups, but I think the important thing to keep in mind is that they didn't provide any data on the level of cognitive impairment between the two groups. So despite them using different methods to define MCI, they also didn't tell us what one group versus the other group was in terms of their MoCA score or their MMSE or their clinical dementia rating or their ADL score. And so potentially these groups could have been not equal in terms of cognitive impairment. And then number 3, aside from the allocated treatment, were groups treated equally? Now, yes, I think that they were treated equally. However, 2 things to add to that is because they don't tell us intraoperatively how much of the other anesthetics patients received. It's unclear if the dexmedetomidine group might have received less anesthetic. Dexmedetomidine, as we've discussed, is a sedating medication. And you would think that a patient who's receiving a continuous infusion of a sedating medication probably would not require as much anesthetic. And then the other factor here to keep in mind is that there's no information given about the medications that patients were exposed to postoperatively. So as we all know, surgery can be very painful, and there's no data given as to whether or not one group or another received more pain medication or more sleep medication that may have contributed to delirium. And then the question is, were all patients in the trial accounted for? So I think they did a great job here. They approached 65 patients, 5 declined to participate, and then the remaining 60 patients were enrolled in the study. They made sure to follow these patients after they were discharged and included all 60 patients in the analysis, so there were no dropouts. And then number 5, were measures taken to ensure objectivity? Mostly, yes. I think they showed that investigators' patients were unaware of the treatment group. But one question I had about the study was whether or not the anesthetists were blinded. I'm not sure. They don't say in the study, but I would think if I was an anesthetist, I would want to know if my patient on the table was receiving a sedating infusion while we're doing this surgery. So I'd think that they probably weren't blinded. Again, this could potentially lead to bias if an anesthetist knew that they were receiving continuous infusion of dexmedetomidine. That might lead them to use less of their other anesthetics. But potentially, that actually is what this study's trying to show, is that potentially dexmedetomidine does have properties that lead to less neuroinflammation, but also maybe it's just a safer sedating medication that allows patients who are at risk of delirium to be exposed less to other more harmful anesthetics. So now just looking at the results a little bit more deeply, we saw that the study did show that there was a significant reduction in the risk of developing post-op delirium in the groups that received dexmedetomidine. But as we see here, the confidence interval is very wide, and this is probably due to the use of a very small sample size. Only 60 patients were involved in this study. But I do have confidence in the results overall, despite the very wide confidence interval, given that we have a lot of previous studies that have also demonstrated the effectiveness of dexmedetomidine in reducing the incidence of postoperative delirium, and also in this vulnerable population of elderly patients. And then also looking at the cytokines that were explored in this study, my one question that the authors don't answer is why they picked these factors over any others. In my reading around the neuroinflammatory hypothesis of delirium, many other cytokines were brought up as related to delirium. So IL-1, IL-6, IL-8 are all pro-inflammatory and have all been associated with delirium. So I do wish that the authors had gone into a bit more detail as to why they picked these factors and not others. So overall, how are the results of this study going to impact how I care for my patients? I think that the patients included in this study, we see, but more rarely, these were younger geriatric patients that are community dwelling with minimal comorbidities that debatably have mild cognitive impairment. So these are patients we see from time to time. I'm undergoing lap chole. Now, I think for the most part, we see patients who are older, who have more comorbidities, and especially when doing inpatient consults for delirium, we see patients who undergo much more invasive, significant surgeries. a laparoscopic cholecystectomy is pretty mild compared to other longer surgeries that some of our geriatric patients are exposed to. And then there's a question around the MCI piece where I do have my concerns around the study's definition of MCI. Number two, is the treatment feasible in our setting? So yeah, dexmedetomidine is used often in our ICUs, and I think this study and the ones that I touched on previously should just continue to enforce what we already know, that dexmedetomidine should be used in elderly patients undergoing surgery, because it can certainly reduce the risk of postoperative delirium. And then lastly, will the benefits outweigh the potential harms? Yeah, I think that the possible side effects of dexmedetomidine, bradycardia being the most important one, or also hypotension, these weren't apparent in this study. Again, a small sample size though. But overall, I think the risk of bradycardia is not as significant as the potential benefits of using dexmedetomidine to reduce postoperative delirium in vulnerable brains of our patients. So that brings us to the bottom line here. So I think what this study does is it confirms what we already knew, which is that dexmedetomidine compared to placebo will reduce the risk of postoperative delirium in elderly patients. What this study does take a step further is that it's trying to look at a more vulnerable subset of our elderly patients with MCI. And many studies have shown that patients with MCI and dementia are at higher risk of developing postoperative delirium. Now, whether or not what the factor there is whether or not delirium itself is directly causing more damage to neurons, which is progressing someone from MCI to dementia, or from a moderate dementia to a more severe dementia, or whether the delirium is unveiling a vulnerability that someone was going to progress anyway. That kind of remains to be seen. But I think the study, in its attempt to show that patients with MCI who are more vulnerable to developing postoperative delirium, these patients in particular should be receiving dexmedetomidine intraoperatively to help reduce the risk of postoperative delirium. And then finally, this study attempted to lend further evidence that dexmedetomidine is effective by reducing neuroinflammation. Yeah, I think overall, I hope that what I've said in this study will help you to better understand the mechanisms of delirium, because it is very complicated. But when we have a medication like dexmedetomidine that is acting directly in a way that we understand how it is changing or helping the cytokines of our patients, it makes it a lot easier to understand how it can be helpful. So thank you guys for your attention, and I'm happy to answer any questions.
Thank you very much, Alex. I definitely appreciated the exploration of the pathophysiology for delirium. Very nice to see that detail being explored. Carol Cohen, one of our geriatric psychiatry colleagues, writes in the chat box, and I felt this as well, that the rate of delirium at 33% seems very high for this procedure. Alex, as you mentioned, the laparoscopic procedure is not as invasive as some other procedures. Clearly, they needed a geriatrician as a co-investigator to ensure degree of cognitive impairment was better characterized in each group. So, Alex, I wonder if you have a comment on the 33% incidence of delirium in their control group. Also, by post-op day 7, I don't think they actually articulated or demonstrated at what time point post-op those delirium events occurred, because you would suspect that maybe they would be home.
Yeah, so firstly, it's a great pickup on the higher incidence of delirium. From what I read, it looks like for most surgeries, the rate of delirium for elderly patients is 27%. That's kind of the going rate. What the authors say is that the 33% is evidence that patients with MCI are at higher risk. And that would be why that number is higher. But I agree with you. I think a geriatrician being involved in these patients would have been helpful. And yeah, Dr. Gandel, also another good point about the study not including the timing of the delirium. They indicate in the paper that this was one of the limitations. And I do think if they could do it again, they would have not only included the timing, but also done a better job of standardizing the definition of MCI and doing a better job of delineating all the medications that these patients were exposed to. And finally, following them a little bit longer and to find out how long did it take for delirium to resolve in those patients that had post-op delirium.
Great. Murray Norris writes in the chat box, given the IADL rating scale was impaired, it looks as if mild dementia may have been the issue rather than MCI. That could explain the higher rate of post-op delirium in a relatively low-risk procedure. And also the 3D CAM instrument may be more sensitive. But she also says, excellent, very well explained study. You were successful in presenting a clearly complex topic. So 2 minutes to the hour. Any other questions? Please feel free to unmute, raise your hand, or in the chat box. I might offer that a few of the prior trials on dexmedetomidine were influenced by the funding source. Dexmedetomidine is an expensive medication. I don't think it's been genericized. This one clearly does have a statement articulating that the funding came from I believe, governmental source in China, but that has been one of the potential sources of bias in other dexmedetomidine studies.
That's so interesting. I wasn't aware of that.
Great, thank you very much, Alex, and thank you, Jenny, as well.